So first off, we'd like to thank Mölnlycke for sponsoring this session, and it's my great pleasure. My name is Kim LeBlanc, and I'm going to moderate this session, and I have the great privilege of introducing our next two speakers. And when you hear their talks, you're going to realize how things can happen and how great collaboration can be. Before we get started, though, many of you, I'd like to thank you for completing the survey that we did looking at pressure injuries, knowledge, attitude, and practice in Canada. And we had 580 people that responded to the survey that we did, which we are quite pleased with that number. I had no great expectations. Anytime someone sends me a survey, I have to admit sometimes I just kind of put it in my outbox and forget about it. So I really appreciate everybody filling out those surveys. The other thing, we started looking at the results of that, and it's timely in terms of the presentations you're about to hear, because when we looked at what the respondents were, about over 80% of people acknowledged that yes, pressure injuries were a problem in their healthcare settings, but the sad thing is many are saying that they're still not. Less than 50% are actually monitoring pressure injuries on an ongoing basis, and less than 50% are actually putting in many of the protocols that we need to be doing to prevent pressure injuries. So we're waiting. You stay tuned. We will have the full results that we will publish, but it's really pointing out that we have a long way to go in terms of the knowledge, attitudes, and practices around pressure injuries across Canada. So you don't here to hear me speak. We're here to be some great speakers. We have Dr. Chester Ho, who is a professor and division director of physical medicine and rehabilitation and endowed chair of spinal cord injury research at the University of Alberta. His CV is phenomenal, including having studied in Cambridge and at Harvard. And I was telling him that, for me, anytime someone studied outside of Canada, I automatically think they're smarter than I am. He has a special clinic and research interest in rehabilitation of persons with spinal cord injury, specifically on the health services delivery of persons with spinal cord injury, as well as the management and rehabilitation of complications following spinal cord injury, such as pressure injuries, and use of functional electrical stimulation. He's also part of the Consortium of Spinal Cord Medicine Clinical Practice Guidelines, the second edition. And when were those published? A few years ago. They were published a few years ago. So in addition to all this academic pursuit, he also holds a number of provincial and national leadership positions related to pressure injury. He's a co-chair of the Alberta Health Services Pressure Injury Ulcer Prevention Committee, and he also co-chaired the revision of the Canadian Spinal Cord Injury Pressure Ulcer Strategy, which was sponsored by the Rick Hansen Institute and Ontario Neurotrauma Foundation. We also have today Marlene Varga presenting, and she's a pressure injury prevention lead. She's a registered nurse and wound care clinician. She's completed the International Interprofessional Wound Care course from the University of Toronto and the Masters of Science in Wound Healing and Tissue Repair from Cardiff University in 2013. And if anybody knows about that program, it is an extremely rigorous program, and I think probably one of the hardest master's programs around. So my hat goes off to Marlene for undertaking that program. She's passionate about collaboration, patient advocacy, patient-centered care, and pressure injury prevention and management. She currently works as a pressure injury prevention coordinator in Edmonton. So please join me in welcoming Chester and Marlene.
Thanks. And I think the reason that I'm here today is just to really share with you what we have been trying to do in Alberta as a province to try to prevent pressure injuries. Not that we are any better or more ahead than other provinces, but it's just a provincial approach that we have taken just to show that we can learn from each other. And before I start, though, just want to say that there's no financial disclosure. I don't have any honorarium or anything for this session. The objectives today are to review the history of our committee, the Pressure Injury / Ulcer Prevention Committee, and also to discuss how an evidence-based approach was taken, and to discuss the achievements of our committee and also what our future directions are. I'll try to make it fast because I have about 50 minutes. And so the history was that, As you know, pressure injuries are nothing new, right? They've been around forever, and yet we still have a lot of them. So we should do something about it. However, I am actually ashamed to say that we did not really have a provincial committee to look at that in Alberta until we had Accreditation Canada, including pressure injury prevention as a required organizational practice. We really should have been doing that without that, but I think that there was a good enough reason for us to get started anyway. And for Alberta Health Services to be accredited, it is our mandate for Alberta Health Services to be accredited by Accreditation Canada. So in 2014, this committee was started. It's co-chaired by myself and also Donna Daniak from Edmonton, and supported by the accreditation team for our province. Now, it was started off as the PUP Committee, Pressure Ulcer Prevention Committee, but then as the term was changed to Pressure Injury Prevention, we thought, are we going to change from PUP to PIP? And so in the end, we decided, okay, let's be inclusive. We'll call it Pressure Injury / Prevention Ulcer Committee, so it's PIOP or something. But anyway. Okay, so the membership is a very multidisciplinary, and we had administrators, clinicians, frontline people, and managers, as well as our partners from Covenant Health and Covenant Care. And we had our first meeting in May of 2014, and the goal was to get ourselves ready for accreditation for 2015. So that did not give us much time, did it? I'm sure that many of you have gone through accreditation, right? It takes a long time. Plus, also, it's not just to get through accreditation, it's to make it sustainable and to make a real change in our culture and practice. So that was an ambitious timeline given to us. And so we thought, well, how do we start? We don't even know what's going on in Alberta. So what we did was we had initially an environmental scan around our province to see how our frontline clinicians actually did and how our facilities did with pressure injury prevention, what they knew about that, and also what was being done about it. So our environmental scan consisted of these areas: risk assessment, best practice, protocols, and also wound care team concept. We heard a lot about team concept this morning, right? So it's very important. And also, what about documentation? How do we do that? Education and tracking and monitoring. And we basically had quite a good feedback from across the province. We found a common theme, a common pattern around the province. It doesn't matter whether it's from the north, south, or central. It's the same pattern. Basically, we found that most staff were using a risk assessment tool. So that's good. However, the knowledge on the evidence was lacking. And also, there's a systematic lack of standardized documentation that was actually not surprising, but also still shocking. And also tracking. Okay, so we knew there are pressure injuries out there, but we are not tracking them. And also, we don't really review our data, even if we had data that people could be reporting, right, for the occurrence of pressure injuries, but we are not really doing any formalized tracking. So we know that we got lots of work to do. So that's back in 2014. And so in order to move this forward, we decided that we really ought to take an approach that's evidence-based. And we wanted to have evidence to demonstrate the need for systematic approach to address pressure injury prevention provincially. So that was done through our survey. And we wanted to use existing evidence-based guidelines and resources for this work, because we know that there are lots of really great guidelines out there. There's no point for us to reinvent the wheel and do more guidelines, right? Why not use the existing, really excellent guidelines? And we also want to generate evidence to show how well we're doing, because guess what? We can always claim that we're doing well with pressure injury prevention, but until we have evidence to show that we're doing well, we're just saying it, right? We need data. And so we could get data from auditing, which is a process thing, as well as prevalence data. So what have we done so far? Now, so far we have achieved the following. I'm just going to go through each of these 7 points quickly. And the first thing was that we standardized our tools and guidelines, and also we standardized our tools for screening. We also developed some additional educational resources. We collaborated with our subspecialty partners, recognizing that there are different needs in the different subspecialty areas, and also we try to align with other programs, which I'll talk a little bit about. And we also started to do more monitoring and quality improvement processes. And we also talked about the governance for this provincially as well. So let's just go through these. So in terms of the tools and guidelines to facilitate the accreditation survey, as I said, there are already excellent guidelines and tools out there. So what we did was, with the consultation of a very broad and multidisciplinary group, we agreed that for the adult population, we'll use the Braden. And in fact, most groups were using the Braden at that point anyway, so that's a good thing. And for the pediatric group, we really, did not know exactly, what to do about that initially, and because different groups were using different tools. Groups were using Braden Q and also Glenmorgan, etc. So initially, we felt that okay, we had to settle on one tool to start with, and then let the subspecialty area try to do some more exploration and also some more trialing to determine which tool was the best to use. And so initially, we decided that we should go with the Braden Q. And at this time, we have the Glenmorgan tool being trialed in Alberta. And also in long-term care as well, we are trialing a reassessment interval and the different intervals that we can be using. So these are ongoing projects. In terms of the educational tools, we have worked with, again, the different areas like pediatrics, etc., to develop different resources. As you know, really, there's a lot of good educational resources out there already. So we just added to the existing resources what we thought would be useful for our context, for our province. And we basically review the different tools out there and then try to borrow the different pieces to make it our own that will be beneficial for our staff. And this is not intended for you to read. Basically, this is a copy straight from our website. To show you that we do have a website for our health services, telling people where to look for their tools and resources for education for pressure injury prevention. Now, the next thing is collaboration with different subspecialty areas. When we first started, we were just rushing and trying to get through accreditation, right? But we soon recognized that, you know what, we really have to pay more attention to the different subspecialty areas because they really have different needs. Pediatrics, they have the different needs, and continuing care, the same thing, and surgery, there are some great questions, right? How about pre and post-surgery assessment? How about patient, in the emergency room? How do we actually handle those? Those are, I'm sure, discussions that you must have had with your colleagues as well. So we wanted to reach out to the different subspecialty areas to see what we can do so that the one-size-fits-all approach would not be there. And we also started to reach out to our partners within the health services as well to try to make this more sustainable so that this is woven into the fabric of our healthcare system. And the two groups that we have been reaching out to are the Clinical Knowledge and Content Management Group and also the Clinical Information Systems Group. With the first group, they actually have been doing educational resources for different areas in our healthcare system. And so by working with them, they actually added to our team their expertise and to create another tool for education for pressure injury prevention. So that was great. And that was also then to be used by not just the wound care people, but by multiple disciplines in future as well, multiple areas, shall we say. And so the same tool could be used for, emergency, by internal medicine, etc. They can pick and choose the modules they need for their own purposes. And then for the clinical information system, that is definitely a very important area that we want to work with because we are in the process of revamping our clinical information system in the province. And so it's important for us to build pressure injury documentation, etc., into the electronic medical records so that it's standardized and so that we can potentially even pull data electronically from the health records so there's no double entry or anything like that. And so there will be a long-term project, but we have started on that. And then in terms of monitoring and quality improvement, we started to do our audits 2 years ago. And we have been getting the groups together to determine how often we should be doing the audits, and then the data would be uploaded into our what we call the Tableau dashboard system for our health services. We have a centralized electronic dashboard system for our health services, so that basically data like that can be uploaded to the dashboard so we can look at how we're doing real time. And so basically, in the end, we hope to see that we have real-time data that can be uploaded for people to see, to look at how we're doing with our auditing and even with our prevalence in future. And similarly, for data analytics, we really want to figure out how to do a better job with prevalence and outcome measurement. Now, we still haven't figured out how to do prevalence. How many of you out here have a great way that you want to share as to how prevalence can be measured? Because I would love to know. It's such a difficult thing, right? Do we do a snapshot sort of thing to flip people over and look at their skin, or do we actually look at documentation? Do we do what? And it's very difficult, right? Because every single system has its pros and cons, and we also recognize that we have limitations with our resources as well, and so we have to take all of those things into consideration. So we're still looking at that, but we certainly are looking at how we can use things like our administrative database to achieve that. In fact, that's one of my research projects, to see how we can use the ICD-10 codes, which are used for the discharge abstract database, to see how we can look at the documentation of pressure injuries from that discharge database. And while it's definitely one way to look at that, but we recognize that it is grossly underreported, because basically it is up to the physicians to document the existence of pressure injuries, and we know that physicians are not necessarily the best group to document pressure injuries. I guess you agree. And so basically, when we look at that, it's going to be a flawed system, right? So I think that I'm hoping that in future we can have the opportunity maybe to look at documentation by nursing and by allied health, because I think that will be a lot more accurate. So now this is the last piece that I want to talk about, but it's also a bit controversial. It's about governance. So there's been so much discussion in our group about this. And I wonder what your opinion is either as well. Because we talked about, okay, in order for us to really make a change in people's practice, we have to look at how we shift the culture, how we actually help people think that pressure injury is really important. And yet, there's another camp thinking that, oh no, we need to have really strict policies and we really need to hold people accountable through the policy. So is cultural shift, policy, so which is more important? What do you think? I think in the end we agree that we need a bit of both, because if you just have policy, basically you can certainly have people just checking the boxes, right? Oh, we've done this, we've done that, but it doesn't really change real practice, and so we think that we need to have both in the end, and it's been a very controversial discussion among our group. So what are we doing in future? In future, we'll be flipping the slides, I guess. Okay, thank you. And so basically, well, we recognize that we started our group in response to the need to meet Accreditation Canada's required organizational practice. It was, a good reason, but not really shouldn't be the reason to do this work. And so at this point, we are very keen to move forward to not just focus on accreditation and to really see how we can change the culture and change the practice. And we also recognize that, prevention is one thing, but we need to really merge with our group that works on management of pressure injuries. So we need to look at both together. And so there's a lot of ongoing work, and the several areas that we are focusing on right now are the following. We want to look at the incidence and prevalence, how we measure that. That's so difficult. But like I said in the beginning, without this data, I think it's hard for us to A, make our case to ask for resources, to get support for our work, and also B, how do we demonstrate the work that we do? How can we show that we really have made a difference, right? We need data. And number two, we need to align ourselves with the clinical information systems so that we have a better way to capture the documentation. And also education is another big topic. And we have also discussed this work with other jurisdictions like the UK, because the NHS has done a great job there. So we have some learnings, right, from other people as well. And also, in fact, next week we have our strategic planning day for our group to get together to sit down and figure out exactly what we want to do strategically as a group and how we move forward together. And so, just to summarize, our PRUP committee was started in 2014, and we have been using this evidence-based approach to enhance and create structures, processes, and outcomes for pressure injury prevention. And we are now at the point that we need to move on to our next phase and expand that work to other areas such as management, so that we can be more effective. Thank you.
Thank you very much, Chester. It's my pleasure now to carry on this conversation about setting the standard for pressure injury prevention in practice. And my disclosure is that I've received an honorarium for this presentation from Mölnlycke. So what I'd like to do this afternoon is to review the impact of pressure and shear on pressure injury development. We're going to examine the outcomes of using prophylactic dressings as a viable option for pressure injury prevention. And the challenge for you is to consider the opportunities to improve processes and set the standard for prevention in your area of practice. So I think it's really important for us, if we're going to be preventing pressure injuries from happening, that we have some basic understanding of the underlying etiology. And it's important to understand that when we have perpendicular pressure or parallel shearing forces, this is causing compressive loading on our tissues. And with this compressive loading, it's important to understand that cell deformation happens. And this means that the pressure is causing pressure on the cells, disrupting the cytoskeleton, and basically the cell can die. And this can happen quite quickly with a great intensity of pressure. And of course, when you're dead, and this is irreversible. And so this is in contrast to the long-held theory of ischemia, which was predominantly the leading theory for pressure injury development. But we need to know that with ischemia, we've got a lot of lead time before the cell actually dies. So the challenge for us is when we're trying to mobilize the intrinsic factors for a patient, we need to focus on mitigating the extrinsic factors that are detrimental and are factors for the development of pressure injuries. So we need to minimize those magnitudes and exposure durations of compression and shearing loads. And we know we need to do this over bony prominences where pressure injuries develop, and we need to do this in a timely fashion. And we do this by implementing surfaces or different devices in practice. So I'm sure you've all seen these, I hope so. So we have best practice recommendations for the prevention of pressure injuries. We know that the patient is always at the center of our decision making. We know that we work in teams, we set goals, we evaluate outcomes. And we also have guidelines for pressure injury prevention. And within those guidelines, there are some considerations for the use of prophylactic foam dressings in practice. So we're going to look at some of the evidence surrounding that. So this is Dr. Nick Santamaria and colleagues in 2013 who conducted one of the largest randomized controlled trials, the Border trial. And what they did was they randomly allocated 440 patients who were coming into an emergency setting that were going on to a critical care area. The patients who were excluded from this study were patients with spinal cord injury, pre-existing pressure injuries, or any type of trauma to the heels or the sacrum. And so in the intervention group, there was 161 patients, and these patients received standard preventative care, and this included a low air loss surface. But these patients had applied a prophylactic multi-layer foam dressing to their sacrum and to their heels. The control group received standard preventative care with a low air loss surface. And the results of this study were that the intervention group, 5 patients developed pressure injuries compared to the control group where 20 patients developed pressure injuries, and these results were statistically significant. And so this same author went on to determine the cost of pressure injuries in that particular study. So the total treatment cost was just over $25,000 compared to the intervention group, which only cost just over $6,000. So here's where you're spending 3.6 times higher when you have these pressure injuries. And we need to understand, too, that it's typically not the dressings that are raising the cost, it's the time that we're spending on treating and managing that pressure injury. So I would ask people, too, to have some type of understanding of how much you're spending on pressure injuries in your areas. And I think you need to know that number. You need to know what your prevalence is at, convert that into a number, and make sure that your managers and directors know how much you're spending. So another study by the same author, which was the Border 2 trial, and Dr. Santamaria took a prospective cohort of 191 patients, once again in a major trauma critically ill situation, the same exclusion criteria. And once again, a multi-layer soft silicone foam heel dressing was applied in the emergency and throughout the critical care stay. And the comparator group for this study was the control group from that Border 1 study of those 152 patients. And the results were that the incidence of heel pressure injuries was significantly lower in the dressing group of 0% compared to 9.2%, and once again, this was significant. So here's another example of the economic impact of adding another tool into your toolkit for pressure injury prevention. So this is a retrospective observational cohort study over a 6-year period that looked at 38 academic medical centers, examined over 1 million patients, and in these academic medical centers, they were using preventative care, but they were also using prophylactic foam dressings. And what they found was that they reduced the cost of treating these pressure injuries, which were stage 3, stage 4, or unstageable, the reportable ones, and they saved over 60% in terms of cost for treatment. But more importantly, the addition of this into their toolkit saved patients from developing these full-thickness pressure injuries. There was at least one reportable pressure injury per quarter per facility that prevented these pressure injuries. So here's another example of keeping our patients safe, preventing adverse events, but also saving costs. So shifting gears to heel pressure injuries, this is the most common facility-acquired pressure injury. We know that there's a lot of risk factors for the development of heel pressure injuries. We know that diabetes is certainly significant if we have a loss of sensation or poor perfusion. We also need to know that the connective tissue also changes with diabetes, which puts our patients at risk. We need to understand that the anatomy of the heel is also a problem. When you have the posterior prominence of the calcaneus basically poking out, you have a lack of subcutaneous tissues, lack of muscle tissues. You have a tendon in that area, and these areas are avascular. You certainly have a less surface area to redistribute that load, which is another problem. Circulation changes, tissue perfusion changes in certain patients, and of course this area is going to be of the greatest risk for developing a deep tissue injury. So we all see this classic patient position, the head of the bed elevated and or pillows underneath the heels. We need to understand that pressure is a problem, but also shear is another problem here. So when we're elevating the head of the bed, our heels tend to drag or ding into the bed, and then the patient is going to adjust themselves and once again dig their heels in even more. So the heel exposure to shear is going to be increased. So just one tip for people, when you're putting your patient in this position, always go down and lift up their heels and reposition their heels to relieve that shear strain that might be going on. So heel offloading, of course, is going to be most effective, but we all know that in certain situations, patients might not want to wear heel offloading boots because of comfort or adherence, and that's a challenge. We need to know, too, that if we're offloading heels with either heel boots or pillows, that we're actually increasing the pressure to that sacral area. So if we're doing that, we need to increase our interventions to the sacral area. So in some situations, in the operating room, for example, there are using protocols and using prophylactic foams rather than heels to keep the heels safe and to keep the sacral area safe as well. So this is an example of computer finite element modeling from Levy and colleagues in 2015. And this is just examining, and this is a good picture to show the problem of the anatomy of the heel. When you have that calcaneus bone just sticking out, you've got that Achilles tendon that kind of acts like a peg in the middle of your soft tissue. And what they examined was this volume of interest where the majority of the pressure and the shear is going to cause these problems. And they examined the use of multi-layer prophylactic foam dressings compared to single-layer dressings and compared to no dressings at all on the heel in terms of compression and shearing stress. And they developed these heel model variants and applied different types of compression and different types of shear. And what they found was, in the A picture on the top, this is with the dressing off. You can see in the redness, that's the intensity of the pressure and the shearing force. And in B, actually is the shear strain. So having the dressing on significantly reduced the compressive pressure and the shear strain in this area in that particular model. So that's one of the mechanisms of action too, using a prophylactic foam dressings is the dressing will take that pressure, take that shear and dissipate it and deflect it away from that bony prominence. So for the use of dressings in pressure injury prevention, there is a consensus document, and some of the indications for using these dressings are when you have a reduced or restricted mobility, or you have any type of atypical movement or prolonged procedures. Your patient might have loss of sensation that reduces spontaneous movement. These are effective used under medical devices, under scars from previous pressure injuries. And it's also an opportunity to teach and educate our patients about pressure injury prevention and empower them to maybe use this and adopt this into their practice. Just listening to Robert this morning, I mean, if he was a patient that was maybe going for a procedure or waiting in the emergency room for long periods of time, maybe there's no surfaces there, there's nothing there to offload this. If we educated our patients and let them know about this, they might be able to choose these prophylactic dressings to use for prevention. So the challenge for us is to, we've talked a lot about pressure injury prevention throughout the morning and this afternoon, and there seems like there's a lot going on, but we need to take all this information and we need to put it into action. So I've been an advocate for pressure injury prevention for years, and I think we need to continue to talk about it, but we also need to put these words into actions. And we also need to have targets set for our areas. So is your target to have a vision zero of zero pressure injuries, or you need to know what your target is for your particular area. So the theme of this conference is evolving over time, and I feel like I've been evolving over time because I've been an advocate in acute care setting for such a long time that my organization has finally recognized that yes, maybe there is a problem of pressure injuries, and we need to actually dedicate one person in a full-time role to figure out how we can improve that. So I have so much gratitude for my organization to recognizing that you need one person or who's going to bring together that team to move pressure injury prevention forward within your organizations. I personally think that we still need a policy for pressure injury prevention or a policy for education. We need to standardize our protocols. But we also can't just rely on risk assessment. We need to be, people keep talking about what are those interventions, where is that care plan, where is that shared communication and collaboration, and I think there's a lot of work that needs to be done around there. I hear a lot of talk about wound care rounds. We need to be talking about safe skin rounds or pressure injury prevention rounds and making sure that we have those interventions in place. And I truly think that from the senior leadership team all the way down to the bedside, to the housekeeper, to the ambulance attendants, to the first responders, everyone needs to know some information about pressure injury prevention. And just a note about Twitter, that's an excellent way to share and learn some information all over the place as well. Also, if you want to get really creative, this is just a shout out to the people in my organization at Covenant Health who are celebrating Stop Pressure Injury Day, and we made it a whole week. And this is my colleague Melissa Crozier, and you can see that she's very good with a sewing machine. She took a soaker pad and basically identified they weren't using soaker pads appropriately in their facilities. They were layering them up. This is causing excess pressure, roughness on the skin, increased moisture. So if you can dress up like this and make your point, she made her point and made some change in her area. So, in summary, minimizing magnitudes and exposure durations of mechanical compression and shear stress is key for pressure injury prevention. Prophylactic multi-layer foam dressings can be an effective and cost-effective adjunct to enhanced pressure injury prevention practice. And we need to continue to advocate, communicate, and incorporate standards to include and engage our patients and our families and our communities and our health authorities and all healthcare professionals. Thank you very much.